So welcome to this webinar. It's part of a global oral health series that is being undertaken by the Global Child Dental Fund, which is a UK charity. And I am Professor Raman Bedi. I am the chair of the Global Child Dental Fund. Today, we're really delighted to have Dr. Alya Elgamri, who is working in Sudan. Alya is a specialist pediatric dentist at the Al Musa Specialist Hospital in Khartoum, Sudan. And she has been working on the EndIOM campaign since 2018. And recently she published a paper in the British Dental Journal on empowering women, which is a public health strategy to end IOM. So Alya, welcome. We're really delighted that you could join us, and we look forward to your talk on the EndIOM campaign in general, and more specifically, the work you're doing in Sudan. Over to you.
Thank you very much, Professor Bedi. Thank you very much for this opportunity. It's a pleasure and honor for me to be with you today. So I'm starting this webinar. Yes. Today I would like to talk about infant oral mutilation and reflect on our experience in Sudan in trying to eradicate infant oral mutilation. So the objectives of my talk today is to improve understanding and knowledge of infant oral mutilation, to explore the IOM situation in Sudan, and to evaluate and analyze the effort that has been made so far to eradicate IOM in Sudan. And just to start with, what is IOM? I'm just giving a brief introduction about infant oral mutilation. IOM is a term used to describe the traditional practice of removing the canine buds in order to alleviate teething-related symptoms like fever and diarrhea. And this practice is usually done by traditional healers, by old family members, could be grandfather, grandmother, sometimes by priest and imam, any religious leaders, or even sometimes by midwives or traditional birth attendees. And the myth behind this African practice is that ancient people, African people, believed that the swelling in the gum pads appear in the children's mouth at around 4 to 5 months are corresponding to delivering primary canines. It's usually a growing worms. This is the myth they believe. And that's why in this practice, they're trying to inoculate these worms from inside the jaws. And how it's usually done? It's usually done by using a sharp instrument or any metal hard instrument. Some of the traditional healers, they heat this instrument, or some of them, they don't heat it. But for sure, there is no sterilization, and they use it between child to child to inoculate the gum pad, the tooth bud from the jaw. And some of them, they use it just for lancing for the gingiva in order to induce bleeding, and they believe that will alleviate the teething symptoms. And what are the consequences of this barbaric action? Usually there is an immediate and late consequences. And also there is a general complications or consequences and some dental or oral complications. For example, for immediate consequences, some of the children may develop bleeding, some of them develop septicemia, infection, and tetanus, for example. Some of them get viral diseases like HIV because, as I said, there is no sterilization between child and child. They're using the same instrument for all children. And there's some reports from Kenya about children who died from this habit, from infant oral mutilation. Also, some children may develop anemia due to the blood loss. And for the dental complication, most of the children who are subjected to this habit develop either missing canine. The canine will be missing completely if the inoculation was completed, or they may develop enamel defect. So we find hypoplastic lesion on these canines, And the lesion may be on the primary canyons or the permanent canyons. Also, they develop some malocclusions related to, for example, midline shift or sometimes other forms of malocclusion. Taking into consideration all these consequences and bearing in mind that there is actually no medical benefits for this practice, we can fairly say that IOM is inhuman practice and that violates the right of children, the basic right of the children. And that highlighted why we should all be fighting this practice. And when we look in the literature, looking at why people doing this, despite the myth they are believing it, and actually why it's still until now, it's very common to happen, we find that the main risk factors are related to strong belief in traditions, because this practice and other harmful practices are widely practices in culture and in regions where people have a strong belief in traditions. In tribes, they follow traditions strongly, and where people, they have no education. And this both factors combine with the weak healthcare system that will lead to people seeking medical advices from traditional healers or from all personnel or at their tribes. So we think that, or we believe these three factors together are the factors that led to this habit being still alive until now. And is it common or not? It's very common. According to estimations that until now there is over 25 million children in East African region are affected by the IOM. And regarding prevalence, from particularly in countries, the prevalence differ from country to country, and even within the same country you will find different studies reported different prevalence, because it depends on the tribe, or it was in a rural area or an urban area the study was done. But generally, for example, in Sudan, the prevalence range from, I believe, 10 to 20. In Tanzania, there is so many studies ranging from 5% up to 20, 25%. In Kenya, the prevalence up to 35%. In Uganda, it's also around 30%. So it's very common. And we also believe that even these prevalence are high, but it may be even there is an underestimation, because usually there is some tribes that may be very close and the practice is very prevalent within the tribe. It's happened that I remember one of our colleagues he was reporting that the people think this is the normal thing that should be done. So we think that it's very common, the IOM. Furthermore, with the significant escalating figures of international migration across the globe, now we have been seeing a lot of multiple case series and case report from non-African countries like in Europe, in USA, Australia, New Zealand, and they document the existence of IOM among immigrants of African origin. And some of the report, they report that this practice have been done in the home country. So the parents, when they go to their home country for a visit, they will practice that the IOM there. But other reports, they report that it have been done in the new country. So all if they have an old member of the family, he will be practicing the practice in the new country. So I think we should by now being like acknowledging that IOM, it's not an African issue. It's a global issue. So everyone should be working on eliminating and eradicating this habit. And now I would like to give like a reflection on what we have been doing in Sudan for the last 3 years. And this reflection is open for critique, for appraisal, for discussion, because we want to learn more from it, and we want other people to get like the positive side of it and the strength point we think that we reach, and we want to work in our limitation, because we will be following on this and we would like to continue our work on this. And this is the whole point on reflecting in our experience. So Sudan is a country on Northeast Africa, and IOM is very common in Eastern Africa, And I don't think it's reported in any of the North African country like Egypt, Libya, Tunisia, or Morocco, but it's very common in the East Africa. And Sudan, being a northeastern country, it took this habit with the Eastern African country. Furthermore, the first ever published case about IOM was published in the 1932, and it was in a Nilotic tribe, that the tribe they are living around the Nile. And that's why we believe that this habit like migrate with the Nile with these tribes, and that's why it's reached in Ethiopia and Kenya, and it's going that way. And our total population is around 40 million, and this population is very diverse because, as I said, that we have more than 7 different countries, and we have a great diversity. We have around 600 groups. We are speaking about different tribes, and we speak more than these, like 600 groups have more than 400 different languages. And that's, we can understand why, like we have wide diversity of different culture and different traditions and different habits. And regarding the IOM, in the literature, there's so many terminology describing this practice, but in Sudan, we call it hayfat. And the hayfat, we are mainly describing the practice of lancing over swelling alveolar process of an unerupted canine with a sharp heated instrument until bleeding occurs. But the action of the complete inoculation of the tooth bud is called lugbara, and this is more common in the south of Sudan, southern Sudan, but in the north of Sudan, we usually call it hayfat. And in 1989, Baba and Key, they have a study where they refer to this traditional treatment practiced in southern Sudan, and here they call it lugbara. And this was the first report from South Sudan about the IOM. And then Dr. Fatma Al-Khidir in 1992, she got the first prevalence study from Sudan, and she reported 22% of her sample has a IOM confirmed. And then we came in 2018 and we decided to update the data from Sudan. So we conducted a prevalence study. This time we wanted to report on the prevalence and risk factor of the IOM among preschool children in Sudan. And our key findings were, we have 2 main key findings. The first one, that we found that 1 in each 10 children in our population have been subjected to IOM that we confirmed by the clinical examination for these children. 1 in each 10. And we think this is the high prevalence, 1 in 10. And here are some clinical pictures from the children. We see that, like you can see that some of them have complete inoculation of the tooth. So the primary canine is missing. And some of them, they have a hypoplastic canine where the inoculation was not completed. And the second key finding that we think that is really important finding, that we found the main risk factor for the IOM are diarrhea and mother educations. Diarrhea, it makes sense because parents link it to teething problem. So when the child has diarrhea, whatever the reason is, they will think that this is teething, so they will perform an IOM. And then we stop in the mother education. In this study, we found that mothers who were less educated, which means illiterate or had only elementary school education, were more than twice likely to subject their children to IOM. And we think that this is a key finding and very important thing to stop it. And when we look more in the literature regarding this finding, we find that there is a considerable body of literature highlights how giving women autonomous decision-making authority by education can have a positive impact on children's health outcome in sub-Saharan African countries in general. And this is not only regarding infant oral mutilation. This is well documented in the literature regarding female genital mutilation and regarding vaccination. So all this, the study or the literatures found that educate the mother and empower them with education and give them autonomous decision making will make them make a better decision for their children's health. So we believe that unquestionably that educated mothers were found to deal more correctly with their children health issue. And we consider this as a starting point for our work in eradicating or trying to eradicate infant oral mutilation. So by that, we start our journey by organizing, raising awareness campaigns in Sudan in order to help to stop or eradicate infant oral mutilation. And these campaigns were organized by the DCRI organization in Sudan. They help an organization performing, they provided the teams and they provided the fund to perform these campaigns. And our primary question was how to create an attractive and motivating way to exchange EndIOM information. Because now you want to eradicate and you want to fight a habit that is enriched in the culture, that is deeply rooted in our culture. So how can we make like a motivating way and a very attractive way in order to exchange the information? And in order to do this, we went through 6 stages in each campaign, and that helped us to really exchange the information with the targeted population. We established our overall goals, objective, and expected outcomes from these campaigns, and we built an effective team. We trained them very well, and we chose them from dental students, dentists, and volunteers, and local people from the area we are going, medical doctors. We have a team up to 25 personnel. And then we identify the targeted population and we collect our initial information about the population we are going. So if for example, Arabic language were not common speaking there, we will take with us a translator from local people. And we collect the whole data we could do before going to them and approaching them. And of course, we select good communication tools and we plan our activities ahead. And after finishing all this and we do the campaign, we do evaluation and documentation to help us in planning the next campaign and to learn from the mistakes or limitation we had and to correct it in the next campaign. So regarding the communication tool that we chose to deliver our message and how to raise the awareness about the infant oral mutilation, we decided to do a group event, person-to-person contact, presentations, radio and TV broadcasting, and printed media like posters and fact sheets. And regarding the activities we decided to do after careful consideration to the population we are going to, we decided to do, or this is what we have done already, community-based education, school-based education, training of health science and medical student teachers and midwives, education of the mother in Obs-and-Gynae hospitals, and initiate media campaigns at the places we go, provide free medical services, educate medical field personnel at that place we go, and give scientific lecture and discussion. And finally, we did some research activity in between all these activities. And for the rest of this webinar, I will just take you through, like to give you just a glance at our activities in the past 3 years. To eradicate infant oral mutilation in Sudan, we decided to work on 3 states. The first one is Khartoum state, which is the capital state and the most populated state in Sudan. And then we decided to work on the Blue Nile state. And the Blue Nile state, it has a border with Ethiopia. This is the one with the blue, this is the dark blue state here. And it has a border with Ethiopia, and they share so many culture and so many traditions. And we know that infant oral mutilation is very prevalent, and they have high prevalence of it in Ethiopia also. And then we chose South Kordofan state, where according to our initial data, the EndIOM is very prevalent, and it's just they consider it as a norm practice in South Kordofan state. And that is why we chose to work on these 3 states. And we perform a complete raising awareness campaign in each state. And each campaign lasted for around 7 to 8 days. And in each campaign, we had a team of 25 personnel. So the first activity we did, it's community-based education. In this activity, we gather community people from all over the places. We just conduct like this like this activity. We did this in mosques, we did it in markets, in hospitals, in streets, in schools, wherever we can have a bunch of people, we will stand there and speak to them about infant oral mutilation. Within the community-based education, we conducted focus group discussion. But at the focus group discussion, we targeted the religious leaders, the traditional healers, and the teachers, because we believe like they have a strong influence. So we conducted like focus group discussion with religious leaders, discussing with them, knowing their views, because people in villages and in rural areas, they listen very well to religious leaders. And that's why we wanted to have them on board with us. And we find a lot of support from them. They said if this cause harm, if there is no benefit, this should not be done. So they were big support. And we conducted a focus group discussion with traditional healers. We wanted to listen from them. We didn't want this to sound like we are here, we against you. We wanted to listen from them, and we want them to discuss like a point of view. So some of them, they felt that, yeah, you are right. And some of them, they have resisted because, to be honest, there is they got money for this service they provide. So it's not easy for them to let it go. But we tried. We conducted this focus group discussion, and for us, it was a good opportunity to listen from them and to know even the technique they use and what they're doing. And we tried to educate them about the risk, and there is other better way to manage fever and to manage diarrhea and everything. And then we also speak to a lot of teachers. We conducted focus group discussion with teachers because we believe that we will be here only for 7 or 8 days and then we will leave. But teachers can be considered as like training of trainees, so they can continue delivering this message and raising awareness at this place. And then the second activity we did was school-based education, where we visited school, we visit kindergartens, and in this we just give like regular dental oral health education for the children. We provided some of the prevention and fluoride applications, and we give them like we did oral examination. But we also speak a lot to teachers at these visits, and we like discuss the issue with them, and we give some education about the risk of infant oral mutilation and how it should be stopped. And because in these places you will find the teacher has a strong ties with the family and with the mother, and if a child is sick, the teacher will be the first to know that he didn't come to the school today because he's sick, he has a diarrhea or he has fever. So we want to make sure that the teachers, they know that it's better to advise the mother to go to the primary healthcare center, then they go to the traditional healer. And the third activity we did was training. And we focus on the training to train midwives and health science and medical students. We give them training about infant oral mutilation, the risk of it, because according to some informal reports that the midwives, they perform infant oral mutilation and traditional birth attendees. And that's why, beside also female genital mutilation, some of them will be practicing this. So this was a whole education about harmful traditional habits, including infant oral mutilation, female genital mutilation, and other traditional habits. And it was received very well from them. It was really good received. Our fourth activity was providing education to the expecting mother. So we target obs and gyne hospitals in every city we visited. We will pay a visit to the obs and gyne hospital, the big governmental hospital, and we speak to the mother, to expecting mother. What we did in these sessions, we give anticipatory guidance about teething, about what to expect, what could happen, what is the causes. We give a very simplified messages about the immunity of the child and how is at this age, it's a transitional stage, about common viral infection and how it's common to have fever or to have diarrhea and how to deal with it and where to seek information, where to seek remedies, and the risk of performing infant oral mutilation, what could happen. And actually the mother were really keen to listen. So this was a very good activity that we conducted in the 3 states when we visit. The first stage will be to go to the obs-and-gyne hospitals and educate the expecting mothers. And then we did media campaigns by doing radio broadcasting. And if there is a TV stations, we go to TV stations. But in most of these, because it's a very small cities, they have only radio stations. So we did the radio broadcasting. And in this radio broadcasting, we will get a local translator with us because there is some local language. So we'll provide the information in Arabic, and then they will translate this information about ending or infant oral mutilation into the local language. And with all these activities, usually we will provide free clinical services to the local people at these places, because from our experience, we found that providing free clinical services will make people come. So like, for example, 1 week before the raising awareness campaign, we will start doing some advertisement and marketing about the doctors that are coming to provide free medical services. And usually, because for this campaign, we had a very good funds, so we will able to get our instrument and all the equipments we need, and a lot of medication. So we will get a pharmacist with us with a lot of medication, and then we will get some basic instrument, and we can do like very good clinical services for simple things, of course. But it was really needed in this rural areas. So people come, like for example, per day we serve more than 200 to 300 patients per day, and we stay for around 7 days. And for all these people who come to get the free medical services, we will get, of course, education, we will give them flyers, we speak to them. So we deliver our message through this. And then what we decided to do also is educating the medical field personnel at that places. So we visited the hospital, the governmental hospital, and we speak to them, to the technicians, to the nurses, to all doctors there, because what we felt that if you are practicing in a rural area for like 10, 15 years, and then you keep seeing these habits being practices, you are no longer like fighting, or you are no longer delivering a message of stop doing this, because you are not used to it, but this is the common, this is the norm in the place you are practicing. So we feel that we have an obligation toward the medical personnel to tell them you are doing great, and what you want, what you believe is the right thing. Don't get carried on with the norm, and keep fighting. And we have these posters and flyers, and we post it everywhere in the hospitals. This is for the medical personnel and for the people who visiting the hospitals. And then what we also tried to do was conducting scientific lectures. And we're conducting around 3 or 4 big lectures about infant oral mutilation. And this is one of the lectures that we have a visiting Professor Kimoli. He is the president of the Kenyan Pediatric Dental Association. And he visited Sudan and gave a wonderful lecture about infant oral mutilation. And these scientific lectures and in this scientific lecture and symposium, actually, we target pediatric dentistry specialists, public health specialists, because we want them to amplify the message. We want them to teach, because most of them are lecturers at the governmental and private universities. So we want them to carry the message. And actually, after this scientific lecture, the last time I communicate with my colleagues, I found that now 8 universities, they teach about infant oral mutilation in their undergraduate curriculum. And I think this is a good improvement, because now for the medical personnel, they will be aware of this habit and how to fight it and the risk of it from the undergraduate level. So I think giving scientific lectures is a very good way to keep the momentum going. And in between all this activity, we have done some research activities. Like, for example, when we visit the school to do the education, we will collect some data about the children who have complication or dental effects from the infant oral mutilation. And when we visit the healthcare care personnel. We get their, for example, their awareness level and their clinical experience with it. And of course, all the research activity we do is IRB approved, and we get a consent form and everything. And then we publish what we can publish from this result, and the other we use to evaluate our work to see the effect of what we are doing, if there is a raise in the awareness or not, and to help us to plan the next campaign. And what we have been doing in Sudan, it's not isolated from what is happening globally, because now there is a global effort to eradicate IOM. So what's happening in Sudan, I believe it's happening parallel with what's happening in Tanzania, what's happening in Ethiopia, in Somalia. So everyone is trying to fight. Everyone is trying to do their part of it. In 2018, there was a call of action for IOM eradication within 10 years. And this was signed by a group of policymakers from East Africa. And as a follow-up to this, in 2019, the chief dental officer, with an invitation from the Global Dental Child Fund, they get a presenter from Sudan, Ethiopia, Somalia, Kenya, Tanzania, Rwanda, and Congo to sign the Addis Ababa Declaration. And from that time, we have like a network between the representative from these countries. So whatever we did in Sudan, we reflect to our colleagues in other countries. And whatever they do, they will reflect to us. And we learn from each other. And we try to like learn from the mistake and learn from the positive things. And we just keep on exchanging the knowledge. And organizations such as the Global Child Dental Fund have paved the way for us to do this work on IOM eradication, and they are doing a tremendous job. They are trying to keep the momentum active and keep us going, and they provided us with all the help we want. But I think that despite what we have been all trying to do, we have to admit that it's still, the practice is still very prevalent, and it's deeply rooted in the African culture. We know this and we acknowledge this. And that's what keeps us going. Even if we cannot see the result of our work today or tomorrow or even next year, we know that we are trying to fight something that is deeply rooted in the African culture. And to change a culture, it's difficult. We know that. And that's why we don't get frustrated if we don't see a result in the short term. We know that we need to be patient, because this culture and these practices have been built up through hundreds of years. And we cannot change this in 1 year or even 5 years. We need time to do this. And that's what will keep us going. So we believe that ending IOM, it's our responsibility to end IOM. And it's no longer a dream. For me, I believe it's no longer a dream. It's possible and it's happening. We just need to be patient. And it's not a career focus. It's a life goal, because it's about our children. This habit's affecting our children. So for me, it's a life goal. But also I believe that we cannot do it alone. We need everyone's support, and we need everyone to be on board. And thank you very much for your listening. And I highly appreciate your presence today. Thank you very much.
Dr. Elgamri, thank you so much. What an impressive lecture, and what impressive the work you're doing in Sudan. So congratulations. Recently you've published a really interesting paper in the British Dental Journal about women empowerment and as a public health strategy in the End IOM campaign. Can you just tell us a little bit more about the concept of women empowerment?
Yes. In this article, we try to reflect on the role of women empowerment as a public health strategy to end IOM. Because from what we can see and what the sense we get, that the woman has a very powerful role in the African culture. And the idea is, the problem is there is some other influences and external influences over women to do things that they may not feel they want to do. So what we felt that, and from the literature, that if we empower the woman to say no to things that they don't want, they don't believe that it's beneficial to their children, this could be a very good public strategy to stop or to eradicate infant oral mutilation. So we highlighted on this, and we think that women empowerment, it's a well-known approach, and there is so many validated tools for women empowerment. So we believe if we use this approach and this tool to empower women, and we apply this to infant oral mutilation, it could be a very good strategy to work on eradication of IOM.
Good. No, thank you very much. And finally, Alya, let me just ask, Sudan has many challenges and health priorities. Do you feel that IOM eradication is more visible to your government and to health policymakers in Sudan?
Unfortunately, no. I don't think it's visible. But after what we are trying to do, it's not only me. We have a great team who is trying to push it into the agenda. And we are trying to push it forward. And I believe now we start to listen about it. We start when we have like a local symposium or a workshop, we will get an invitation. Come and tell us about infant oral mutilation. Some of the things that related to the Ministry of Health. They will ask us to bring our brochures and posters if they are going. So we feel that we are starting to be visible. They are starting to see it. And then when we link it to other practices, also like traditional harmful practices, so it's good because we amplify the message now. It's not only IOM, it's a whole package of harmful traditional practices. So I feel, yeah, we will get there. We are going there.
I'm sure we will, and thank you so much. So Dr. Alya Elgamri, pediatric dental specialist at Al Musa Specialist Hospital in Sudan. Thank you so much for joining us today.
Thank you.
And we wish you well. We wish you well with your End IOM campaign in Sudan.
Thank you very much for this opportunity. Highly appreciate it. Thank you very much.
Good.
Goodbye. Thank you.